All right. Well, welcome everybody. Welcome to our webinar today. We're so excited to have all of you here because we've got a special guest, Dr. Simin Gharib, who is a faculty member at Brigham and Women's Hospital and also pursuing her own business at Harvard Business School, group telehealth for women's preventive cardiology health. So Dr. Gharib is going to talk with us about the SGLP agonists, including Ozempic and the others, what we need to know about them for cardiac reasons, diabetes, et cetera. And I just want to thank all of you who've submitted questions online already. We've got lots and lots of questions, and I'm sure more questions will come up as she talks. So please feel free to submit your questions through the Q&A or through the chat. We'll make sure to save time at the end of the talk to address all your questions as best we can. So welcome everyone, and welcome Simin.
Thank you so much, Sarah. I'm going to share my screen and great, and get started. It's such an honor to be here today with all of you. Thanks again to those who submitted questions beforehand. We'll try to get to all of them and any others that come up. But it's very nice to meet you all. My name, as said, is Dr. Simin Lee. I'm very interested in what's called cardiometabolic health, and we'll get into that today. And at this moment in time, we are in the midst of a real breakthrough in the treatment of cardiometabolic health with the introduction of GLP-1 medications. And so we're going to dive in, hopefully, really answer all the unresolved questions that you have about this and help you understand how this might apply to heart health. For disclosures, the only thing to mention is what already has been mentioned, just that I am founding a company with the support of Harvard Business School related to this area. But that shouldn't color any of the information I'm going to share with you today. So GLP-1s, we are in the midst of an absolute craze. There's a lot of hype, a lot of media frenzy around this entirely new medication category, with, headlines ranging from, the emphasis on weight loss to figures in Hollywood and celebrity culture who are on the medications, to the implications for the healthcare system, and even just societal norms around body weight and body image. So everyone, is being bombarded with stories about these medications, and as prevalent as they've been on our TV screens, on our phone screens, in our conversations, we physicians, we in the medical establishment realize there's still a lot that people are trying to understand when it comes to, what about me and my own heart health? I think of my own patients and how they're trying to make sense of all this information. So that's our goal today. We're going to try to really give you a sense for the GLP-1 basics, what they are, how they work, what the background is, how they apply to heart health, what some of the downsides or sort of question marks might be, and then what's coming down the line, what the future holds. So we'll get into all of this today and answer your questions as we go. So let's start with the basics, all the questions that maybe you feel like you should know the answer to, but you're not really totally solid on. We'll start with, what are GLP-1 medications? And in order to really answer that question, we need to take a brief little detour, into the world of hormones and, go back to school for a second. So let's talk about incretin hormones. Incretin hormones are a family of hormones that are secreted by cells in your gut, in your small intestine. And these include glucagon-like peptide 1, or GLP-1, and glucose-dependent insulin-tropic polypeptide, or GIP. There will not be a pop quiz on these very long names. Just remember GLP-1 and GIP. And so what happens is, when you eat food and that food contains sugar, your body senses the presence of sugar in your mouth. And then it signals to your small intestine to secrete these hormones. So here's GLP-1 and GIP. And then those bind to little receptors on the cells of the pancreas called beta cells, which then are told, they're stimulated to release insulin, which is another hormone that helps your body take sugar sitting in your bloodstream and store it in cells so that you can then convert it into energy. And so, that diagram, I realize, is a little intimidating and scientific appearing, but just a very simplified visual breakdown of this is that these hormones get secreted when you have sugar in your mouth. They tell your pancreas to release insulin, which tells your body to take the blood sugar in your blood and put it into your cells so that you can have energy. That's all you need to remember about incretin hormones. And so, what are the effects? What happens, beyond this insulin secretion and putting sugar into cells? There's a lot that happens as soon as GLP-1 and GIP, naturally made by your body, get released by your intestine. So, way up in the brain, there's signals that you're full, that, you feel sated or satisfied. So you have less of a drive to eat. There may be a little nausea that accompanies that, depending on how much is in your stomach. We talked about insulin. It also slows down the rate at which your stomach empties itself of food. We call that gastric emptying. And it helps do other things in the liver to improve your sugar, decrease your sugar production, decrease the amount of fats that your liver is synthesizing. And, both of these have very similar effects with some, minor variations, and together act very synergistically to make you feel full, to slow down the passage of food through your system and your drive to eat, as well as a bunch of other metabolic effects. And so now the medications, GLP-1 and GIP medications, what do? They just mimic this natural, innate hormonal effect that's happening in your body every time you put sugar in your mouth. So these medications are structured to look like your body's own hormones, and they affect everything from your GI tract with that gastric emptying we talked about, your brain, your pancreas and the hormones it's secreting. We've come to understand that there's a big effect on the heart. It helps reduce blood pressure. It might increase the heart rate a little bit, but also make the heart squeeze better. It also helps the kidney get rid of salt, which helps lower your blood pressure. So, and then of course, in the liver with your fat tissue and your muscle, there are lots of other positive metabolic benefits that are happening when we have drugs that mimic these naturally occurring hormones secreted by your gut. So that is sort of a little bit of the background on the science, but how did this all come to be? Who discovered this? I mean, this is kind of trivia, fun fact here, but I have no idea exactly why, but researchers did become interested at some point in what's called the Gila monster, which is native to the Southwest. It's the largest lizard in North America, north of Mexico. And I think they noticed that, wow, it only eats a few times a year, which is kind of puzzling. So these researchers at the Veterans Administration Hospital studied the contents of its saliva and venom, and they identified something called exendin-4 and noticed that structurally it was very similar in appearance to the human natural occurring GLP-1. And it had a very similar effect in the lizard. However, they also noted that it lasted much longer in the body, in the lizard's body, than our naturally occurring GLP-1, which usually gets degraded very quickly. And so they thought, wow, this actually might be a therapeutic, this might have therapeutic potential in diabetes. And so, flash forward about a decade and a half, the FDA approved the very first GLP-1 medication based on that structure of exendin-4, and it was named for that exendin-4 called exenatide, the first GLP-1 medication that was approved for diabetes. So that's the background. Now, 2024, we have so much more than exenatide. We have a whole bunch of different medications. Of course, Ozempic has become the poster child for this category of for this whole drug class. And one of the questions submitted beforehand is like, how do you make sense of the different options out there? And it's totally normal to feel overwhelmed by that. So here's a chart that I found on GoodRx, which has also been helpful in providing coupons as well as education to the public about medications. And you can see that, now we have a bunch of different options, and some of them, they vary based on, how frequently you have to take them. There are some that are daily, there are some that are weekly. And then, most of them are injectable, but there is one oral version, a pill version of semaglutide. Most of them have been approved in type 2 diabetes first and studied in type 2 diabetes first, but we now have the emergence of brand labels approved by the FDA for the purpose of weight loss. So even though the chemical structure is the same, semaglutide, Ozempic refers to the diabetes label that the FDA approved, and Wegovy refers to the weight loss approval. And similarly, Mounjaro is for diabetes, and now Zepbound, which is brand new and not even on this chart, is for weight loss. And so you can see, is it approved for adults, kids, or both? And are there other benefits, which we'll go into shortly? So that's, become a whole family of different medications now. But how do they relate to heart health, which is obviously top of mind for the patients on this webinar and us as cardiologists? This is a very hot topic and definitely one that we want to emphasize in our discussion today. So in order to get into that, like the cardiovascular benefits, we need to first talk about what we increasingly see as part of heart health. So obesity. Before, for a very long time, and for many people, still to this day, the way we thought of obesity is that this is a behavioral problem. People just don't have enough willpower. They're eating too much. They're not exercising enough. It's calories in versus calories out. And you got to just make that a negative balance and you'll lose weight. Very little attention paid to genetics, very little attention paid to the environment, whether you live in a food desert with all this fast food around you. But now we've really evolved. And so 2013 actually was a major inflection point in the medical establishment's understanding and narrative around obesity. It was officially declared by the American Medical Association in that year as a disease, which you don't think of as a big deal, but it helped draw attention to the fact that there is a whole biology to obesity. It's not just about willpower. It's not just about behavior. Of course, those things matter tremendously, but it's a very complex biological process with inputs from genetics, from environment, as well as your own, internal biology. And as you can see, we're not going to go into all of this, but this is really meant to illustrate the complexity, biologically speaking, of obesity and the effects it can have on so many different organ systems, leading to so many different conditions. So that's how we've come to understand obesity. And even more so, we're seeing, just these striking numbers and data come out about the different dimensions of impact on the cardiovascular system and related organs. So, I think a lot of you know this intuitively, but I've put this here and we can send it out later as an attachment. Just some numbers, about like what the magnitude of the association is between excess weight and stroke, heart attack, heart failure, liver disease, high cholesterol, type 2 diabetes, kidney disease, and high blood pressure. These are all interlinked, and we know that obesity drives them, but just seeing how much can be really jaw-dropping and perspective orienting. So, obesity we used to think of it as a behavior problem. Now we see it as very much mixed in with cardiovascular health. And that has led to the emergence of this concept called cardiometabolic disease or cardiometabolic health. We in cardiology now view obesity, diabetes, high blood pressure, and high cholesterol as just as important to the consideration of heart health and a patient's heart health as whether they have coronary artery disease, they've had a heart attack, or they have heart failure. They're very, very linked together with how our heart and our blood vessels are functioning and the risk of problems down the road. So obesity increasingly is coming into the cardiology clinic. So that sets the stage for now talking about what exactly are the medical benefits. And obviously, weight loss is the one that has garnered the most attention. This has been an absolute watershed moment in the medical treatment of weight loss to have these medications introduced. I know that this chart looks very complex, but as you can see here, we have in orange are just normal GLP-1 medications. And then there are other sort of versions of GLP-1 medications that involve stimulating other receptors like GIP that we just talked about when we were talking about incretin hormones. And you can see that on average, people in these clinical trials, people are losing at least 15% on average of their entire body weight when they're on these medications, up to 24% in the most recent studies. And, that's usually if they don't have diabetes. For some reason, patients with diabetes tend to lose less weight, but it's still quite impressive, 15, 16, even 17% of their original body weight, which, for context, just to put this, as a reference point, this really gets us close to the kinds of weight loss we're used to seeing with bariatric surgery, weight loss surgery. So, for those who can't undergo surgery, they're not a surgical candidate, or they're just nervous about surgery, it's been a really important advance in treating weight loss. What about the other benefits? Obviously, all these medications actually started out, as you saw in that chart, as approved for diabetes. And so, with that, we've seen a tremendous benefit in blood sugar lowering and blood sugar control. And, I don't have the data from all of the different GLP-1 medications. Tirzepatide is what's considered to be the most potent for weight loss and diabetes treatment right now. It is a GLP-GIP medication, known as Mounjaro or Zepbound. And so as you can see here, people on the highest dose of tirzepatide are getting like a over 2% reduction in their A1C. And you can see just, how much their A1C drops from the 8s down to normal, almost normal, like a pre-diabetic range on treatment, which for context is closer to what we see with insulin, maybe metformin, but a lot of the other diabetes pills do not get you this much of a reduction in A1C. And fortunately, there hasn't been as much low blood sugar with these medications because of the way that they interact with that complex web of hormones. So weight loss, blood sugar control, cholesterol control. We've seen with Mounjaro here that all the cholesterol, the good kind HDL, the bad kind LDL, moves in the direction we would hope. HDL goes up, LDL goes down. Triglycerides, which are fatty acids that we believe also have a role in heart disease risk, go down. So, very favorable changes that we, are coming along with the weight loss. And then, of course, there's actual cardiovascular disease, things like heart attacks, heart failure, strokes. And so, in the very early diabetes trials, we saw like a glimmer of a signal that there may be a relationship between these medications and cardiovascular disease. So this table is ugly and busy, but these up here, you see the names of all these early trials looking at GLP-1 medications in type 2 diabetic patients. And you can see that in 3 of these trials, I've just put boxes around them, there was a statistically significant reduction in what's called MACE. So the combination of heart attacks, strokes, and death from heart-related causes. So that's what people saw early on. And they wondered, well, what about, maybe this is because type 2 diabetic patients, they are already carrying so much heart disease risk and they're kind of already set up for heart disease. But what about in non-diabetics? And so that brought in something called the SELECT trial, which made waves. It was definitely written about and featured on, on the news last year in November. Big trial looking at patients without diabetes who either had known heart disease or very high risk for it. They got Ozempic, the semaglutide, which is like Ozempic, versus placebo. And, I didn't think that in the era of cholesterol lowering medications like statins and aspirin and good options for blood pressure control, that we were going to see a huge difference on just a few years time frame. But lo and behold, we saw that the GLP-1 medication reduced death from heart-related causes, heart attacks, or strokes, all combined, by 20%, which is really very powerful. And they didn't even use the highest dose in this trial. They also noted that there was a big heart failure benefit, that there was a big reduction in obviously death from heart-related causes and heart failure visits to the ED, as well as hospitalization. So that was unexpected and very encouraging. So this is what we've come to see in terms of the cardiometabolic and even the cardiovascular benefits of this new drug class. But what about lifestyle? We're always talking in clinic about a heart healthy lifestyle, heart healthy diet, and exercise for your cardiovascular health. So how does that fit in? And that's a really important question. I think a lot of my patients that I've spoken to, they feel like a lot of shame, that like they failed over and over with lifestyle, and that treating their weight and their cardiometabolic health is an either or situation where like either they're going to be focusing on lifestyle or they're going to be getting medically treated. But increasingly, the field is moving towards looking at lifestyle and medical treatment of cardiometabolic health as synergistic, enhancing each other. And there's actually been a lovely study to demonstrate that. So just last year, I believe in October, we saw a study published in a great publication looking at this very question. What happens if you take patients who are overweight or obese with diabetes, you put them through a lifestyle program, so a low-calorie diet, counseling on exercise, and then just general frequent health coaching sessions. Those people lost around 5% of their body weight. At that point, they then randomized them to either get tirzepatide, which is Mounjaro, the really effective GLP-1 GIP medication, or a placebo. And what they saw is that medication helps them, in combination with their foundation of lifestyle that they had built during the program, help them go beyond what had been observed in the normal Mounjaro trial, 20% weight loss, to 26.6% weight loss. So we really want to shift the narrative away from like either you're doing lifestyle or you're doing medications to saying, hey, look, we now have emerging data showing that these two should be combined, and that if we can combine them successfully, we can achieve an even better outcome for your heart and metabolic health. So that's sort of a bit on lifestyle. Now, all really encouraging, exciting information. This is like, I think somewhere where we get very anchored on all the positives. But of course, with every medication, every procedure, there's questions, there's potential downsides, risks, and we want to cover those today as well. So let's first talk about side effects. Excuse me, this is a very common topic when I'm helping patients, start these medications or they're already on them when they come to me. I think far and away, because of the effects of these medications that we reviewed, the most common side effects are gastrointestinal, nausea, abdominal pain, constipation comes up a lot, sometimes diarrhea though. And so up to 50% of people will have at least one of those side effects. I will say in my own clinical experience, these tend to be extremely manageable, either with modifying, meal content, meal portion size, or frequency, or, fiber intake. These all tend to be quite manageable and rarely present a barrier to continuing treatment. Sometimes people can feel fatigued, in part because they're probably just not eating as much, like as they start this medication. And of course, because most of them are injectable, there can be some skin irritation. Again, there are lots of ways to address this. For the fatigue, I often counsel my patients, especially if they work and they have to go in person to work, to think about maybe a Thursday or Friday injection day if they're taking a weekly medication, so that they have the weekend to kind of lay low and recover a little bit if they are particularly hit by fatigue. And similarly with skin reactions, I encourage people to rotate injection sites so that they, minimize irritation in the same spot over and over, and so that they also can avoid scar tissue buildup underneath the skin that can affect your body's ability to absorb the drug. So all very manageable. Of course, there are some more serious effects or observations that have been made that are worth discussion every time, I'm in the clinic with patients talking about these medications. One is pancreatitis. So, in less than, I put 1%, but really in less than 1% of cases, we can see acute pancreatitis, which would manifest as very severe abdominal pain in the upper abdomen, sometimes sort of feeling like it's going to the back. So, that can happen very rarely. Similarly, gallbladder inflammation can happen in very rare cases. In animals, in like rodents, there's been an observation of medullary thyroid cancer. That has not played out in the human studies, but it's something that would make a doctor think twice, and a patient, if they or their family members had a big history of thyroid cancer. There are other important considerations. There's a small signal towards the possibility of worsening diabetic retinopathy. So for any diabetics who are getting these medications, we just want to make sure that they are very plugged into regular eye care. Gallstones can form even if you don't get gallbladder inflammation. And then there's been this question of suicide ideation that's emerged in the media. Lots of sort of, reports of potential increase in suicidality or thoughts of suicide. And the FDA is actively investigating this. And just, every few weeks, they're putting out a new update, and they are going through, they're mining all of the clinical trials that have been done to date. And so far, there is no data to suggest a causal link here, but it's something that we're watching for. I will say in my own practice, I am seeing a lot of the time, I'm actually seeing the opposite. I've had patients who feel very depressed when they're so overweight, and then, with medication, it's like a catalyst, and they start undergoing not just a physical transformation, they start feeling much better internally and psychologically. And so, I think that, I think it's something that now with the possible reports, I would think twice as a physician if someone had a history of depression and, suicide attempts or thoughts of suicide. But so far, we're not seeing a big link there. What about other things? So cost comes up, and the consequences of cost. So just to put some numbers to it, the cost situation is not something that the economy, whether it's on an individual household level or a macroeconomic national level, global level even, that we can bear forever. But just so you can see, if someone were to try to go to the pharmacy to fill a prescription and insurance were not covering it, you're looking at around $1,000, even more, $1,300-$1,400 per month to fill a supply of these medications, which is just, completely unaffordable to the average American. And, of course, like, despite that, we're seeing just so much increase in the volume of sales and prescriptions filled for these medications. So, that's despite this price point. The hope is that with more competition, more innovation, there's more drugs in this family, in the pipeline, that these prices will come down. And of course, in about like 15 years, the first one will come off patent, and then the price will really fall. But this is definitely a very important issue in the dialogue right now around GLP-1 medications. And with the incredible increase in demand, people are not only facing high costs, but they're also facing shortages. So, I saw some of this in the questions that were submitted beforehand. Some of you have run into the problem where you go to fill your prescription and you go to refill it and they don't have it. I've tried to start many diabetics on Ozempic and overweight people on Wegovy, and I just can't do it anymore because the lowest doses are not available. Now, some of this is driven by the demand, which you're seeing here, visually depicted here in the number of prescriptions by drug and how it just really is exploding in 2023. But some of it's also just supply chain related. The parts and materials to make the pens that deliver the drug have reportedly been in short supply, and a rate limiting step in getting the medications to the people who need them. So those are some issues. And as a result, with the high cost out of pocket and the shortages of the brand name drugs, we're seeing some people turn to other options out of desperation. So one is compounding. And I don't know if you guys have heard about this, but there are certain pharmacies, specialty pharmacies, that have the ability to make a compound version of a drug. And, I think in lay terms, you might call this like a knockoff or a Me Too version of the drug. And this for certain pharmacies and under certain conditions, like when a drug is officially placed on the FDA's drug shortage list, can be legal and overseen and, all over the table. But what's happening now is, obviously, given the demand for these medications, there are a lot of pharmacies that are not, approved to do this, or that are not employing, good practices. For example, sending patients the raw ingredients, asking them to mix them themselves, not requiring a provider's oversight to go along with the prescription. And so there are some people who, in this case, they're getting no guidance and they overdose essentially. And so, we have seen some very unfortunate developments, deaths, obviously overdoses, poison control calls, with this proliferation of compounding use or off-label use of, the diabetic version, for example, instead of the weight loss version. So these are some of the consequences of the economic realities of this market. Another issue that comes up all the time is this question of regain when someone's taking this for weight loss, whether it's weight loss in combination with blood sugar control or just weight loss by itself. Probably the number one question I get in my own practice is, well, what happens if I stop it? How long do I need to be on it? And so this has been studied. This is a trial looking at semaglutide, which is, again, Ozempic or Wegovy, and they randomized patients with overweight or obesity to be on semaglutide or a placebo drug. And then they, kept them on. They're on the highest dose. They lost a lot of weight. Looks like it was 18% of their body weight. And they were also, importantly, getting a lifestyle intervention, counseling, usually recommendations to follow a low calorie diet, to exercise, etc. Then at 68 weeks, they stopped everything. They stopped not only the medication, but also the lifestyle counseling. And what they saw is that people went from having lost around 17% to having lost a net of 5-6%. So that's approximately a regain of around 2/3 of the weight lost. And so, that's pretty powerful data. It can make some people feel a little bit nervous about, like, well, what am I getting myself into? Am I going to be dependent on this? But I think, for us, it inspires more questions about, like, well, what if we had continued that lifestyle intervention? Or what if we had sort of, worked more intensely on the lifestyle piece to help maintain the weight loss? I think that question is unresolved. So we just have this one piece of data. It's a real concern, but I think, I certainly have treated patients or encountered patients who have lost, 100 pounds. They come off treatment and they maintain it because they've made so many changes in the way they eat and exercise. So that's sort of a whirlwind. What are the basics of GLP-1s, the benefits for cardiometabolic health, and then some of the, concerns. Now let's look to the future. What does the future hold in this rapidly evolving field? So first, let's talk about some of the other benefits, medical benefits, that are being investigated and that we have some preliminary data on. There was a trial stopped early at the end of last year looking at semaglutide in chronic kidney disease and trying to see how does this affect or not affect the progression in chronic kidney disease to, for example, dialysis dependence. And they actually had to stop the trial early at 1 year because to continue it would be unethical based on how effective it was at slowing down kidney disease, and it'd be unethical to withhold that treatment from the placebo group. So we're seeing some signals that these medications, again, maybe because of how they affect salt filtration at the kidney level and just overall cardiovascular health, that they may really impact the kidney as well. There's a lot of interest in some preliminary data showing a potential dementia benefit. One of the most interesting use cases is around substance use. So whether it's smoking cigarettes, opiate use, alcohol consumption, or even, vices like gambling, which I know isn't substance use, but it's similarly categorized. There's some preliminary data suggesting that GLP-1 medications help reduce all of that, reduce cravings. And the thought is that it's through a decrease in what we call dopamine levels, which is a neurotransmitter associated with reward. We're seeing a lot of emerging data around fatty liver disease, which is quickly becoming the #1 cause of liver failure in this country, and how fatty liver disease can be put into remission with GLP-1s. And we're also seeing a lot of increasing research in the area of polycystic ovarian syndrome and related infertility, which, has insulin resistance underpinning it, and where GLP-1s sort of have a lot of promise to help younger women struggling with weight and related PCOS to conceive and start families. So those are some of the emerging benefits. We mentioned that there are drugs in the pipeline. One of the most exciting is called retatrutide. I'm sure it'll have a much snappier name when it's FDA approved. This is the results of a phase 2 study where what is it? I should even zoom out further. It's like Mounjaro in that it's a GLP-1 GIP medication, but it additionally stimulates glucagon, which is like the foil hormone, the anti-hormone to insulin. And so that triple combo ultimately achieved, 24% weight loss on average at 48 weeks compared to 20% for Mounjaro. So, there's even more effective therapies coming on the way, and that'll be exciting. And again, just the more drugs that are available, the more competition and the more the prices will come down. Even more exciting and advanced is the concept of gene therapy. So there's a company called Fractal based in Lexington, Massachusetts, founded by a former Brigham cardiologist, actually. And they have conceived of a way to go in and edit the genes of pancreatic cells to essentially turn on GLP-1 without a medication. And what they have seen is that has really helped, compared to just taking Wegovy or Ozempic in mice, they haven't started human trials yet, produce a greater weight loss that's much longer lasting. So that may be the future for where we're headed. But I recognize that was a lot of information. I'm sure I already see hands raised and Q&As in the chat. So I will just pause here and see where our discussion takes us. But thank you again for the invitation to come and meet you and speak with you today. And I'm really looking forward to talking together.
Fantastic. Thank you so much. And you can stop sharing screen so we can see you. So that was amazing. And what was amazing about your talk is that I think you covered 90% of the questions that have come up, because I think in your day-to-day interaction with patients who are taking these are the things that we hear all the time, right? Like, sounds great, but there must be a catch. What's the downside? And
Yes.
what happens if I can't get it suddenly? And I think, the barriers to taking it, I think we see the benefit, right? And we probably all, if not in our own lives, have seen people lose weight who have been trying everything. And as you said, they've tried exercising, they've tried eating right, and feeling that kind of banging their head against the wall for years and years. And finally, these injections are allowing them to do that. And there's a virtuous cycle too, because I've seen people who right now, they'll go to the gym and exercise, and they don't have that sort of what's the point feeling anymore, because they start to change. So it's amazing. I think the question that'll be the $1 million question, and I think you've seen it in your patients, is if you're able to get these lifestyle changes going, you're starting to make better choices about eating, you're starting to move more, your knees don't hurt as much, your back doesn't hurt as much as you lose the weight, you can do more. Is it then going to be possible, realistically, to stop these injections and maintain those healthy lifestyles and maintain some of that weight loss? What's your gut feeling? Because I think we've also all seen patients who've really tried to maintain the lifestyle, but when they stop the meds for whatever reason, it's a big backslide.
Yes, I think it's possible. I think it's on us collectively as both, in healthcare, but also, in collaboration with patients to, like to really devote some thought, energy, and just commitment to the lifestyle piece. Like I hear, what you just articulated about some patients' journeys where it's been a lifetime of effort, that feels like it's just not translating into any progress. And it's so discouraging. It's so demoralizing. There's so much stigma and everything. And now there's a solution. I look at it almost like a catalyst. And then, you mentioned like all these, certainly there are physical things that happen. I mean, just offloading not only the joints, not only the back, but the heart, like decreasing the pressures inside the heart can make it so much easier to move. And if it becomes easier to move, then you can have that sort of feel good feeling when you are exercising, virtuous cycle. And then suddenly you're like, well, what happens if I just, sort of greenify my diet and everything, right? So all these things I think figuring out how to start that virtuous cycle, if a patient has not naturally fallen into it, is going to be critical, because the people that I see coming off and maintaining the weight loss are the people who have fallen into that virtuous cycle. I have plenty of patients who feel like, look, I'm overloaded. I'm like, it's all I can do to just remember to take the medication on the day I'm supposed to, and to grapple with some of these side effects, and to make sure that my insurance company is going to cover it next month. And I just don't have the cognitive energy or space to be making a salad right now. And I understand that. I totally understand that. But I think when someone's ready, and maybe even a little before they're ready, trying to help them set themselves up to get into the virtuous cycle, I think that'll be helpful. But of course, it's not going to work for everyone. We all have our different biologies, and that's why obesity is being recognized as a disease. So I think in that case, what a lot of my weight management colleagues are saying is it's not just about GLP-1s. The people who really need lasting weight loss, on the order of 25%, maybe even 50% in some cases, they're going to need GLP-1s and lifestyle and something else. Maybe it's bariatric surgery, which we really should, I think, we are trying to normalize a little bit as an option if insurance doesn't cover the GLP-1s, or if they drop coverage, or you can't tolerate them because of side effects. As well as some of the other anti-obesity medications out there. So I think, just trying to figure out, okay, how can we replicate virtuous cycle positive success cases? And then how can we also just make sure that we're not anchoring too much on GLP-1s and we're still thinking about the broader therapeutic spectrum, are the ways that we can help people make sure that once they lose it, they keep it off.
Perfect. Thank you.
Well said. And I'll just share my 2 cents there too, because I think most people are perhaps worried about that long-term commitment. That yes. I think that's a lot, that fear of I'm choosing something forever, right? And I'm not sure that we have the science that really supports that, as you said, right? So I would love it, if we kind of put that to the backseat while we talk about, who's right for these medications. But what I've noticed in prescribing these is some people really have this robust response, and they are just not hungry. And this drive, right, to be eating is completely changed. And I don't think it's as robust in everybody. And maybe you could just say a few words, about your experience with that, yes. Because I think that's really tangible to hear the kind of the different responses.
Yes. No, I think we certainly noticed that. So women, there are sex differences. Women tend to lose more weight, to have a more pronounced weight loss response to these medications than men. Why is that? We don't know. But the short answer is we don't know. There may be some kind of hormonally driven, explanation, but we have not really identified like a compelling association there yet. It may be because women on average are, even if they have an elevated BMI, are smaller than men. And so for a given dose, they're actually seeing effectively a higher dose than their male counterparts. But we know that women tend to lose more weight. We know that non-diabetics lose more weight and lose it more quickly than diabetics, type 2 diabetics. I think that what's important, as you said, Allison, is just like setting expectations. And, I've come to realize like a lot of our colleagues just think, oh, these are so ubiquitous. They're being so they're talked about everywhere. Like patients just know about them. But I think explaining to a patient, this is what we're hoping to achieve. We're hoping to silence that food noise, that background sort of constant thought track about like, feeling a little bit hungry, might go for the Pringles. Maybe I go for like the chocolate covered almonds. I mean, it's like a constant sort of soundtrack in your mind, and having that just suddenly silence, that's really what we're looking for. And so I always tell patients like, start on the lowest dose and let's make sure you're not feeling unwell. But if you don't really notice a major dent in your hunger and your thoughts about food, just tell me. I need to know, because otherwise we're never going to get you to a dose where you're going to really respond. So I think establishing that communication, that collaborative relationship, so that we can get people to where they need to be is really essential.
So you're saying that in a sense, if you don't feel that side effect, it's not working for you.
Yeah, I think there's a sweet spot. Like, I think, the patients, a lot of patients use that term food noise and like having it silenced. And one patient put it very profoundly. She was like telling me that it was as if she put on glasses for the first time and could see clearly for the first time. It was like so profound. And she felt like, oh my gosh, she struggled with weight her whole life. And she said, this is what it's like to be normal. This is what it's like to have a normal relationship with food, not constantly thinking about it. So we want that. If you overshoot it, yeah, it might come with some nausea and some bloating and constipation. But, a lot of patients find that usually attenuates. And of course, having some flexibility about, do you go down on the dose for a week, or do you skip do you just sort of prolong your period of time at a given dose before escalating? These are all strategies we use to try to help people through some side effects and hit the sweet spot.
Maybe you could just speak about that, because I think a lot of people have that question, right? Because there's also that fear, I'm going to just feel poorly, and is it worth trying it? And, I don't have as much experience as you, but I have found that you can really, stay at a dose and kind of gauge, just explore what your body feels like right before we change the dose.
Yes.
Provided that the, supply issues are not.
Exactly. That's the massive asterisk. I think, yeah, I mean, so technically, like when you look at the FDA approval of these medications, there's usually like a dosing schedule, a titration schedule, and every 4 weeks, or every week, if it's Saxenda, like go up, to this dose and that dose. And I used to do that, but now, in part because of shortages and you just never know if a dose is going to be available, and also because of the need to really respect each individual's body and response, my practice is to obviously start at the lowest dose, unless, as in one of the pre-submitted questions, someone is switching, unable to get Ozempic or Wegovy, and they now need to switch to Mounjaro, and we're coming in at not the lowest dose. But start low, go slow. And I kind of just say, as long as you feel, you don't have food noise, and you feel like a curbing of your appetite, and you're not having excess side effects, we can stay at that dose. And when you feel the return of some hunger, you feel hunger creeping in, then it's time to escalate. Or if weight loss plateaus. So I don't really kind of, like religiously stick to a timetable anymore, because, also that puts all this pressure on trying to find the right doses at, and maybe they have to go around to 5 different pharmacies. So I've had some patients lose a tremendous amount of weight on just the lowest dose of Mounjaro. So, I try to individualize and make sure that they feel well, that they're responding, and that we can actually get the medication.
That's great. Someone's asking, are there ways to get around those side effects? For example, the constipation, the
Yes.
nausea.
Yeah. So, I think that's a great opportunity to just examine the diet. I've had a lot of hydration. Hydration is not to be underrated. I think that the more you can hydrate, which often falls to the wayside when you just don't feel hungry, the more you can keep the fluid in your GI tract normal, which will sort of lead to a normal consistency of bowel movement, but also just like what you're eating. So the more, you can have fruits with fiber, or even just taking exogenous fiber, sometimes that can really help with constipation. There are plenty of people who just have diarrhea too. And so that's sort of, that can, again, like, just let's look at what you're eating. Or is it, something with a lot of sugar, or something that's very osmotic that'll pull water from the colon and cause you to have the diarrhea? Do you need Imodium? But usually they're very, manageable is what I would say. The constipation diarrhea is manageable, and they often fade. And in part, I think because people get used to it a little bit and they adapt. And so I find that it's most pronounced in the early part of treatment. And then people tend to either get used to them, or, or figure out strategies to deal with them.
So that's great. So just to recap, these do dehydrate you because they tell your kidney to excrete salt and water.
Yes.
So
And you're not eating, you're drinking as much.
I see. I've found a lot of luck with psyllium or Metamucil, so psyllium fiber.
Yes.
It helps both the diarrhea and the constipation because it
Yes.
just helps the stool up. So that's a nice way to get fiber without, a lot of people eat prunes, but that has an awful lot of sugar.
Yes. Yes, absolutely.
And maybe a good reminder too about how much that portion size really affects you, because I've heard from a number of patients, a meal that I used to consider normal, now I definitely won't be able to tolerate, right? I don't know
Yes.
if you've experienced that and heard that.
Yes, absolutely. And so people, and it's a very striking, it just changes the whole axis of your world, right? I think that it's an adjustment for people to go from these big, these large meals that felt normal, to something that they know their stomach and their gut can handle, and that won't make them feel bad, and to also go from maybe worrying, oh, is this too much food, or is it too fatty, or is it too this, too that, to like, I just want to nourish my body. I just want to fuel the engine. I think that's a big mindset shift. And at the end of the day, promotes a healthier relationship with food.
There was a piece in the Atlantic recently about Ozempic causes not just loss of fat, but loss of muscle. And have you seen that in your patients? And how do you monitor that and prevent that from happening?
That's a great question. That's a great question, and a very important one. So any effective weight loss intervention, be it a therapeutic or some kind of program, will cause fat loss as well as muscle loss. If you're really losing weight, you're going to lose some muscle. But what we want to avoid is losing excess muscle to the point that you feel weak, and maybe it's hard to engage in your daily activities, or to maybe take advantage of this weight loss and start to do some, things that you couldn't do before. So what I have found very helpful, what my patients have told me is helpful, whether I've counseled this or not, I'm learning from my patients too, is protein, really examining the diet for protein and making sure that they're not, as they decrease their overall intake, that they're not skimping too much on protein. And of course, in cardiology clinic, we try to encourage our patients to look at plant-based sources of protein like legumes, chickpeas, lentils, beans, as opposed to meat, but also fish is great, a good source of protein. So that can help maintain muscle mass. And then the other thing that I specifically specifically talk to people about is when they're trying to start to introduce exercise, aerobic, moderate intensity exercise, like brisk walking, I mean, like it's nothing crazy. That's important. That's great for your heart health. But especially when you're on a GLP-1 and you're maybe thinking about muscle mass and trying to stay nice and strong, it's just adding some basic little strength exercises. And it doesn't have, again, just like walking, I try to emphasize as like an accessible, achievable form of exercise. Strengthening yourself and maintaining your muscles also can be quite accessible and achievable. Like, you got a chair in your house, like just stand and sit 10 times in a row, do it maybe a little bit slower as you're going down, and repeat that like two or three times per week. So that's like very easy. And if you have a water bottle or a gallon of milk, just lifting that, you don't have to have special equipment. And, but I think that can really help, prevent some of the muscle loss that comes with the fat loss with these medications.
How much protein do you think people should be eating when they have to make new choices about what they're going to put in their mouths?
Oh, good question. I actually don't have an answer in grams. But I think that, for like lunch and dinner, for example, I think having a serving of protein is important. So, probably doesn't need to be like protein, your entire plate protein, all 3 meals a day. But I think 2 out of the 3 meals, having a portion be some kind of fish or legumes would be very helpful for maintaining muscle mass. And also just, I think, promoting that heart healthy diet.
Yeah, no, I think so too. I think I do promote it at breakfast too. I think I tell my patients to go for about 15 grams at each meal. And
That's
sometimes
great.
now on these meds, they're skipping a meal altogether. So you have
Right.
to really make sure you're getting enough.
Which, like, I have had folks tell me that they will, if they are skipping a meal, but they feel like they can make a shake and sip a shake throughout the day, and there's vegetables in there, they might add some protein powder, flavorless protein powder, and that can be a great way to get it in as well.
Great.
And, our patients, we use the InBody machine in our office, which gives you an estimate of your lean muscle mass, right?
Oh, that's great.
I know this audience gets tired of me harping on the exercise piece, but I think it's so important to remember that. And, just maybe to say it out loud, the studies that we have data on your body mass, right? When you lose fat, you actually 40% or when you lose weight, 40% of that could be muscle mass in the DEXA scan that we have from these trials. So, nobody wants to lose muscle. It's so hard to put it on, right? So I think the protein and the exercise is critical if you're adding these medications to your regimen.
Absolutely. Absolutely. And I think it's just, you want to be able to exuberantly take advantage of the weight loss and other metabolic benefits. So like, you want to be active, you want to be able to maybe travel or go hiking or whatever it is that was hard before. And so I think that can, getting people to imagine, like, what are the things you want to be able to do? Well, then, let's really set you up, not just with the medication, but these other things that can help balance the benefits of the medication with some of the things that may come along with it, like the muscle wasting.
Great.
And I know there's a few more questions, but it might be nice just for you to kind of give a little bit of a summary of who we're really targeting, right? Because
yes,
I think the world is changing so quickly, right?
Yes.
With who is approved and what, like, just where we see the benefits, especially for a cardiology practice.
Yes. I mean, so obviously I think the population, or audience, of people that stand to benefit from at least a conversation about whether these medications are right for them are people who have excess weight. And so, at least by the FDA approval standards and a lot of insurance companies, that's usually viewed as a BMI, which, yes, is not a perfect measure of like your overall health, but BMI of 27 or greater, with at least one other weight-related issue, like high blood pressure, high cholesterol, obstructive sleep apnea, heart disease even. So, that, or just obesity in isolation with a BMI greater than or equal to 30, anyone who has that, and that is 70% of the US population, you know, stands to benefit, at least from a conversation. And then, of course, now in cardiology clinic, there's people with actual heart disease. So if you've had a stroke before, if you've had a heart attack before, if you have heart failure, now this is something to consider on top of the rest of your regimen. I mean, when you think about it, taking what risk you already have on your statin, on your aspirin, with your LDL cholesterol 70 or below, with your blood pressure in a good range, and then reducing it further by 20%, that's amazing. So, I mean, that's like, you know, that I'm now thinking about it for those patients. Patients with kidney disease, patients with diabetes, you know, so the population is really rapidly expanding. But I think probably the first, you know, my flow diagram, when I'm thinking like about the patient in front of me, I'm looking at their weight first, and then the presence of established heart disease, cardiovascular disease. And so, you know, similarly for anyone on the webinar, you know, I think just thinking about your own set of medical issues and your worries, you know, these are the things that I think sort of garner the most attention and that are a pretty, you know, reasonable. I have found it not so bad actually to get approval from insurance companies when you really explain, you know, someone's full clinical picture, the risk that they're carrying. You know, that it's usually been pretty straightforward to get these medications for my patients when they have those conditions.
Perfect. All right. I'm afraid we have come to the end of our hour, and I want to thank you so much. You covered so much. You talked about all the different medications that are available, the different indications, the benefits, and also the side effects, and then sort of practical strategies for who we should be talking to about this and how we can overcome side effects and get the most out of the medicines, especially when we can't always get the doses and the types that we want. But it sounds like future directions are pretty exciting too, in terms of understanding these pathways and helping us use those pathways and these medications to approach the problems that come with obesity and diabetes in terms of cardiometabolic health. So that was amazing. Thank you so much. And thanks to the audience. Your questions were fantastic. I think we covered almost all of them. And I hope you all have a wonderful day. Thank you so much.
Thank you. Good to see you all. Have a good rest of your week.